Welcome, everybody, to the session on Change Ahead, Balancing the Patient and Caregiver Experience in a Human-Centered.
We really have had a program that's been grown over a decade. But as far as COVID, the level of adoption across the hospital of all these different subspecialties has just exploded. The interesting thing, though, is in some cases, some organizations are going to find they're going to go back to pre-COVID when the surge passes. In the case of children's, it's always been part of our strategy. And it's been just a complete pleasure because we've been building these programs over time. But the key is building programs that will continue to have that elevated adoption, not only within your hospital walls as far as subspecialties, but across the community. Our phrase is we like to be where children live, learn, and play. We have a very extensive telemedicine program into the schools. And we've had some interesting ways where we've even been able to redeploy some of that equipment when some of the schools have been going to total virtual. So as we're taking a look at different options, I think like Michelle, you'll find it interesting. The first areas we penetrated relative to deploying telemedicine back into some of the more sophisticated areas in 2013 was the ICUs. Because it's just such a great use case for leveraging that technology. But it's one of those things where before it was boutique doctors that were willing to adopt it. Now everybody's adopting it. They're seeing the utility of it. The patient families aren't going to want to go back because they're certainly seeing the utility of it. And for children's health, we plan on staying with this kind of elevated adoption because it has been part of our strategy. I'm going to pause there because Tamara has a lot to add to this conversation, please.
Yes, I can certainly say firsthand, just kind of operationalizing all of our telemedicine programs since the beginning of our journey. It has a lot of providers, clinical staff, leadership, down to the finances of it all have been pushed into really a new care continuum. For us in telemedicine, we've been waiting for this day. Been working in telemedicine for about 15 years or more in the both adult and in the pediatric space. And we've been waiting for the day. Now, we didn't expect the day to happen in one day, right? and it has. So for us, I just submitted an abstract for our research endeavor, and I titled it 0 to 60 in 30. The deployment of ambulatory telemedicine in our ambulatory spaces, our bedside telemedicine, huge increases, as kind of Pamela alluded to earlier, 16,000% increase. We're at a near 25,000 visits since March 19. So just to step back a little bit for sure, our experience working in the pediatric space really started in our schools. We have around 189 school-based telemedicine sites where we train those nurses to see one of our full-time providers over a telemedicine mobile unit and provide care to those students. So with that, we've done that since 2013, 2014 or so, and we've seen an increase. This for us, and we're used to kind of rapidly deploying. How this shifted, it wasn't the mobile units and that kind of technology that's being used. It's where patients are at home, right? And for us, our pediatric patients at home with their families and using their own devices really to be able to see a provider. So we saw that shift in regard to how that empowered families to be more really in control of their care, understanding what their blood pressures were, even for pediatric patients, and understanding that they can still connect with their provider when they're not either at school or going out to a clinic space.
So the adoption rate is what everyone thought it would be, and here it is. But we also know that in the health systems are used to geography. And geography is really important, but in digital worlds, to use Friedman's term, they're flat. So in the past quarter, as you have been seeing this mass adoption for this technology, have you discovered any new competitors that you weren't tracking before? I'm just curious. Has anyone become aware of a new competitor in this arena?
Yes, for sure. We've in virtual care, we've always had quite a few of competitors, and we like that. That mixes up the game a little bit. The disadvantage of that, though, for healthcare systems is those that have not really had the experience in virtual care are not aware of kind of which technology to choose. I think as Pamela and us at Children's, we work very closely with our technology departments to vet out the technology. What is the best use case for different modalities for virtual care? And with the rapid deployment of telemedicine, a lot of the hospitals just hadn't had the time to really vet out some of the platforms, some of the technology use cases, and it has put them at a disadvantage as we're kind of talking about sustainability of programming. If I've heard, in just my experience working across some of the hospitals in the country, a lot of the telemedicine technology groups are offering maybe free or no pay contracts at the beginning just to get telemedicine started, and then maybe some inflated prices, as we're, down 6 months into the programs. Hopefully that will not happen, and hopefully it's just rumor that it will. And I know they're giving out some freebies, but I think it's very important, and just not the cost, because sometimes you have to buy in and pay in to get what you really need. Cutting costs, cutting on those things sometimes can hinder your program. So I would say for any of those hospital systems, the virtual care department working along with the IT department, with the EMR groups, with the legislation, we've talked about legislative groups inside of your hospital is the best case scenario. So you can have all the players, stakeholders at the table to make the best decision in regard to the technology that's being used and the way the programs are being rolled out. So yeah, we've seen a competition in school telehealth for sure.
Michelle, I think you made a reference to having to train your clinicians and your caregivers. And of course that begs, because everyone seems to be telling me that we're going to see these volumes for a long time. So how do we make sure that our clinicians are trained, like this stuff, are ready to be proficient and effective with the technology we're going to be putting in for our patients? So what steps do you anticipate?
Let me I want to jump back to your other question, because I do think it's very interesting. We were 2.5 years ago, almost 3, when we started our telehealth program. We were pretty much the first here in the Texas Medical Center. And since that time, and the reason that we did it, we had seen where it was coming across the country. We wanted to get it up in place. I think what you find now today, everyone's doing it. Your CVS, your Walgreens, your Walmart, every little shop here. And so that's what hospitals are competing with, right? So it isn't just, and I am agreeing with, Tamara, on the technology, but it also has to be the ease of use for the patient. If it's hard for them to get in and it's hard for them to use, guess what? They're going to go down to the CVS's, or they're going to go down to the Walmarts. And so that's one of the other things, is that, making sure that you are choosing the right technology, not just for the hospitals or the healthcare systems, but also what's the ease of use for the patient to get into it. Now, let me go back and address kind of your other question, which was on training. Yes, I think all of us, and this isn't a unique story to us or, with Pamela or Tamara. If you talk, this is a common story amongst all healthcare institutions right now who are having to deal with COVID. How do you sustain it? Well, this is like any other training. Whenever you come in and you train your docs on how to use the EMR, you've got to be able to train them too on how to do telehealth. How are they going to do it? And, we use, of course, our EMR. We use it as part of our virtual program that we use. And so I think is newer clinicians coming on board, it's going to be easier for them. I think that's the reason we kind of saw the low adoption, which is, from physicians who had been, practicing for a while. They were used to seeing patients, in person. What do you mean I'm going to see them, by a virtual? How can I do that? I need to be able to, touch and, hear things. But I will tell you, we're trying to supplement our virtual health with, not sure if any of you are familiar with Care. It's a device that the patient can purchase themselves. It allows the clinician to be able to, listen to heartbeat, get blood pressure, look in the ears, look in the throat, which helps the clinicians further to be able to make that clinical diagnosis. So how do we sustain this? I think it's just another part of the training that you have to take when clinicians are new to your facility. They go through the EMR training. They're going to go through training on how to do virtual health. And it is our strategy to continue to keep exploring how that we can, do this further. Right now we're kind of taking the Houston and surrounding community, but we do have a very big global population, and we're looking at how we can extend it beyond that as well.
I wanted to underscore a few comments that both Tamara and Michelle were making. One relative to adoption. We had a program in for a good long time, but we were still training 1,300 physicians and 1,000 nurses in the course of this event. So it gives you an idea of just what the scale of adoption is. In addition, when you're really trying to get the adoption in the community with patient families, that's where the convenience factor comes in. Our phrase is, we want to be where children and families live, learn, and play. CVS is convenient. Walgreens are convenient. And Tamara and I were talking yesterday, and many times clinicians don't realize that what's convenient to the patient family might be that Wi-Fi at Starbucks versus in the home setting. And some of the clinicians have had to get used to this new setting for the consumer side of it. And we have to be into that new normal because, frankly, that's where the CVSs and Walgreens are going, and that's where we're at. But at the same time, it took some orientation of those clinicians that were being trained. Tamara may want to elaborate on that.
Yes, for sure. Just for the, convenience, Michelle, as you kind of mentioned, for the patient, when we first deployed our Children's Health Virtual Visit app back in 2015, which is a direct consumer app that allows for patients and both adult and children to be able to see a provider from home, the Texas law stated that you had to establish patient-provider relationship in a clinical location. So that was very tricky because clinical locations were, a pharmacy or a school clinic was one of those. But so we deployed kiosk out to pharmacy areas, retail locations that had pharmacies, and then some private kind of owned living facilities with a medical assistant. So we could have that first visit be done at a clinical location. Then 2017, the law shifted where you could establish patient-provider relationship over video without there being at a clinical location or having a telepresenter. So then we were able to really roll out that Children's Health Virtual Visit platform for them, and so patients could be able to see from home as needed. Medicaid still has a few kind of restrictions in regard to that, but for the most part, you can have an urgent care visit from home. So what we had to really do is look at the technology in regard to what was most effective for the patient, but then also, as Michelle and Pamela both alluded to, what's efficient for the provider. So, we got 1,300 providers more trained during this time. But I think what's interesting is that the training itself had to change. We have a pretty tight curriculum in regard to telemedicine training. A few of the universities here in Dallas have reached out to us to help them develop telemedicine training, which is very interesting. So now they're going to be including it right into their provider training. We have a resident program where the residents come through and are trained in telemedicine and see our program. But what we had to, and a lot of that is didactical, right? So you're in the room with the provider, with a scope, whether it's the Care or the Video or whatever the names are. You're sitting there, you're with the scope, and you're demonstrating really how to place it television to the ear and how to work with it. We had to shift that training to a full virtual experience so that we were limiting the exposure of our trainer team, even though they're clinicians, and then the providers. We wanted to rapidly deploy that. So what we did, what we would have usually done in person, we transitioned that to a virtual experience, either group training or video training. So there's a couple of phases. There's a baseline knowledge of telemedicine that they learn what telehealth is, telemedicine is, and the laws around it, but then also what the technology is, and then some of those basic pieces of knowledge as to how to look through a camera and how to work through those pieces of it and explaining what it is. But we had to switch all of that to a virtual experience due to COVID, which is a fast turnaround and credentialing in 24 hours instead of the usual 2 months that it takes for her. Michelle's laughing because she knows it takes a while to get the credentialing done. But we had to shift that, and our credentialing team was awesome. Medical affairs, they would turn it over for us in 24 hours. And so we got quite a few clinicians, over 1,000 or so nurses trained within that space.
Another element that supported this adoption rate is suspension of regulations. So this is a heavily regulated area, and the regulations weren't always designed to facilitate adoption. So we'll see state by state basis how rapidly suspension becomes eliminated, and that will play out in the months to come. So with that, I think we probably have inspired a lot of questions with the expertise and passion that's on display here. So why don't we check it out and get some questions from the field?
Some questions here, and I was curious if anybody's got some questions that they want to ask already. Otherwise, do we want to let David and some of the other team members on? For some reason, my control doesn't let me turn them on. Apologize for this, guys. We're running into a little bit of a tech snafu, but I'll try to get this cleaned up here in a second. There we go. Hi, Michelle.
Hi there.
All right. So yeah, we'll let the others on as well, and then we'll jump into some Q&A. And while the others are joining, we've got a question from Anjay, it looks like. And the question is, I'd love for the speakers to comment on rural internet access, which is a critical issue for us here in the sticks. I'm not sure what in the sticks means, but Michelle, thoughts on rural internet access?
Oh, I think it's a real problem, and I agree probably with whoever is in the sticks. Fortunately, here within the Houston and surrounding communities, we don't see as much of that as a problem for us. I think as we begin to expand out more within, globally and around further, there is going to be the issue of just kind of, getting connectivity. And it's probably more so of how can we as, the United States and others be able to start to make sure that these individuals have the connectivity. And it's not just even for healthcare. You stop and think about the school systems now and how they're having to provide curriculum to students in that fashion. So I do believe it's going to be an issue that's going to have to be dealt with. But for us right now, it's not something that we're having to really to have to deal with here in this Houston surrounding community.
Got it. And Tamara and Pamela, how about you guys? Hi, Pamela.
Can you hear me okay?
We can hear you, yes.
Yeah. Okay, great. I'll make a comment. Tamara will have a lot to add, but in pediatrics, a lot of this is determined by legislation state by state. And relative to rural areas, up until this last year in Texas, you had to have a clinician on both sides of the televisit. And that really was prohibitive. Even if you supplied the equipment to the other rural location, they couldn't always have that clinician on the other side. They might have a tech-savvy individual. And I have to compliment Tamara and her colleagues because they've lobbied over the years. And just this past year, we got legislation passed that has allowed for a tech-savvy person to be on that other end of the visit. And with that, from a pediatric standpoint, we expect that it's going to open up, but there's still a lot of work to be done there. And I'm going to lob it over to Tamara.
Thanks. Go ahead, Tamara.
That is certainly for sure. Does it look like there's a glaze over my video? I feel like I'm in a shadow, but maybe
You're doing okay.
clearly, and it's just my view. Yeah, since a deployment, I think the rapid deployment of telemedicine during COVID, there were a lot of kind of inequities, if you will, in regard to Wi-Fi connectivity, broadband access. We saw that with schools, right? When everyone in a household, even in a community, was trying to connect up for their virtual education and academies, we saw that same impact on the world of telemedicine, where there were just a lot of families that did not have access to Wi-Fi, even in an urban setting. I'll tell you, we saw that in our DIS, a lot of our school areas and districts in our urban, almost as much as we saw in the rural. Because if you have a lot of people in one location trying to connect, it's almost as bad as not being able to connect when you're out there by yourself. So what we've been able to do is, with the technology that we'll deploy out moving forward for our school telemedicine, we'll probably attach a device along with that to be able to enable more connectivity and do some of the hotspot checking. We're also working with our platforms. And I think this is very important for those of you that are trying to build telemedicine programs. Working with a platform that can be versatile in regard to connectivity. If they can reroute their servers, in the matter of minutes, where it's faced different directions, connecting up with different providers, having the accessibility to do that, and some of them can, that's very important to make them aware that you may just need that, whether rural or urban settings.
Yeah, great point. So Tom's got a question here. As a provider, many talk about disadvantages of telemedicine consultation. What do you see as advantages of the platform beyond just access? What is natural to telemedicine that you could not do beforehand? Such as, for example, knowing the home environment. I've actually heard a lot of physicians say, holy cow, I didn't realize that this is how that patient lived. And so they're able to see things in their natural environment that they wouldn't have otherwise been able to see. That's one example. The other example that you guys
I'll make a couple comments. I did see the comment that came from one of the participants that they like to see the home environment, like you've pointed out. I'm actually a patient right now, a cancer patient right now. And today I even had an infusion right before I got home to do this televisit. On two levels. One, from a physician standpoint, you can queue people up and you have a lot less left without being seen. You have situations where you don't have gaps in your schedule as much. So from the physician side, it ends up being far more efficient. But I'm going to talk about the patient side for a second. And from the patient side of it, I have to say, if I have to wait for a clinician for my televisit, I don't mind when I'm sitting in my home setting. On the other screen, I have my work going on, cup of tea and all of that. But if you're picking up and you're sitting in a waiting room, that can be, it's not as pleasant for people. It's not as comfortable and relaxed as one of the participants pointed out. So I think it's wonderful for the clinicians for efficiency. It's wonderful for the patient families. It's been quite nice from my end when I can do it televisit.
Right, great point. Michelle, any thoughts?
Oh, I would agree with Pamela. I've actually done a virtual visit myself, and you're absolutely right. It is the waiting, and it's not always an instant as that when you get on, but at least that you're waiting in your own home. But I do think it's beneficial for the clinicians to be able to see that home environment as well, because that helps them, really understand what the patient may be going through. But on another question I saw that I just want to be able to address as well, it had to do with, kind of on the consultation. What we're really trying to help with is if you're seeing your primary care and they believe that you really need to have a consult from a specialist, we're trying to see if we can't make that happen then, instead of here's an order for you to go in and go see, this specialist. Why not consult that physician in right away if they're available, so that, the two physicians and the patients are having the conversation. And that's the beauty of telehealth. No longer, will you have to wait to be able to get some of those things done.
Yeah, and I want to echo something. I think that's important. More than a disadvantage of telemedicine, and as we're training providers for that, one of the first things we talk about is what is telemedicine appropriate visit types and what are not telemedicine appropriate visit types. And that is something that you really you cannot do everything via telemedicine. It has expanded in regard to that, especially with devices that can be bought and used at home to see inside the ear. But there are some visit types that are not appropriate for telemedicine, and us in the telemedicine world don't want you to use it, right, if it's not appropriate. However, what we want providers to be able to do is use it for its advantage. So where you see that it fits in your practice, in your healthcare system, the technology is really out there for almost anything you want to do, as you see it as that advantage.
Yeah, great point. And Pamela, I believe there's a minor technical echo on your side. So if you're not speaking, if you can just go on mute, that'll be great. So I'd love to bring up this conversation that happened in Mary Jo's session last session, which was, what is the state of telediagnostics and what is the state of devices being able to help and assist with the telemedicine? And this is probably even more so more true with children, because you need to have thermometers, you need to have remote sensing equipment. What is the current state of remote sensing and telediagnostics, and where should entrepreneurs be focusing on stuff that if you guys could say, hey, I wish entrepreneurs would give me X, Y, and Z, stuff that they're giving you now?
I'll start, and Tamara will have a lot more to add on this front, but one of the things that we actually benefited from and our patients benefited from was being able to track the consumption of medication and have that be automated. So you could, let's say if you had a transplant patient, you could make sure that that patient not only opened the bottle, but it actually was consumed. In adult care, it's not a problem. In pediatrics, we did find a vendor partner that actually would do this. And then unfortunately, their business wasn't able to sustain. So,
oops, looks like Pamela got.
I think we lost Pamela there for a moment. Maybe Tamara can go ahead and take over.
I'll fill in on that end if she jumps back in. Yeah, so what she was just about to also say is, if you're looking at technologies that would benefit in the remote patient monitoring space, those that will be able to determine if patients, medication adherence, it's kind of the medical term that they use for that. So medication adherence is huge in the transplant industry, in the spaces where it's so very important that they take that immunosuppressant drug daily, on time, at the same time. And so remote patient monitoring within that aspect, I think that's what you were alluding to, the RPM and those studies and the work that we did within that space. So I think the way RPM is moving, I'll say a little bit farther, is into the AI of it. You have the devices, you have the information, you have the technology, but where is that predictability? Where do you see any patterns with patients? How can you even prevent certain illnesses in regard to that? So it's that artificial intelligence that's happening across the industries that I think will certainly make an impact on patient care. And we can really see some great outcomes. It's not just looking at the moment, right, or documenting that information, but being able to forecast out what is possibly happening with a patient base and moving forward from that.
Yeah, and just continue on that,
Right.
Michelle. There is this idea that there is a lot of work that we can do from a remote patient monitoring point of view, but are the devices ready? Do you guys have access to them in
Yes.
meaningful enough ways?
Yes, we do. It ranges too. Oh, I'm sorry. Was Michelle?
No, go ahead, Tamara. You can go ahead and answer,
Okay,
and then I'll
sorry.
respond as well.
Okay, we do have a scalable approach for remote patient monitoring. We have a kit that goes home with our transplant patients that it has a Bluetooth scale, pulse ox, blood pressure cuff, and and a tablet. So they're able to get on every morning. They can click through the medications that they've taken. They jump on the scale, or maybe step on the stick scale, and it Bluetooths over what their weight is, the blood pressure, and all of those patients are in a panel, if you will, a dashboard panel. Clinicians are able to view the information of every patient 24/7. If you have a kiddo that is not taking the medication, maybe they're not feeling well, and some of their diagnostics are coming back low, it'll show them in a red zone. And so either the clinician can reach out for a video visit, or the patient can do that and have clearance and have a video visit. So that's the largest population of transplant. But then we also have some complex care patients that really don't require that daily medication intake or the blood pressure cuffs and all of that. So they can, we call it BYOD, and they bring their own device and they're able to download their care management plan into that. All of the kind of registrant groups in the complex care area, what they were doing was calling the patients 24 hours into dismissal home. Now they're able to push that out, and moms, we know, and dads too, we'd much rather get on our app and go through and answer questions and click, 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 than wait on a phone call and talk through all of that, so because you can easily do that at home. So they're able to go through all of their care plan information. They'll ask a question and it trees off yes, no. And if they answer no, it goes in a different direction. All of that information is then integrated into their Epic record, so the providers are able to see all, and you can really track your patients better. So it really goes from a mobile device all the way to a kit of Bluetooth information for remote patient monitoring.
No, that's great to hear. I'm glad. So as a technician, I'm an engineer. We make these kind of tools and devices, but I often hear from our physician friends that, hey, you guys are talking about all this remote patient monitoring, but where are my devices? Like, how do I do this? And so you've got a kit, Tamara, that you prepared. How about Michelle and Pamela? Do you guys do something similar?
Well, we don't have a special kit, as I think I mentioned earlier, kind of, in the presentation, that, we are partnering with a company called Untitled, where it is that anybody can buy those devices. And what it helps to do is to be able to take, your blood pressure, your temperature, it looks in your throat, looks in your ears when you're doing the televisit right at that moment. So that the clinician is better able to provide a diagnosis other than asking questions and taking and seeing you where you're at. But I will tell you, medication management is huge, and I would say not just even for transplant patients. I mean, it's critical if you begin to look at readmissions, and nobody wants to be readmitted. It's after they've gone through, and a lot of that has to do with how well are you, making sure that you're doing the things that your discharge order said to you. Are you taking your medications? Are you eating right? And, that a lot of it has to go with, I will tell you, technology, even from this device right here. If you look at your Apple Health record there's a lot of things that you can be keeping up with, and your exercise that goes directly in to the EMR, and then, notifies the clinicians that way. I will tell you, we're trying to take it even a step further. Telehealth has been great for your after visit surgery, right? How are you doing? But also some of that you look at, you have to do physical therapy. We've been piloting, physical therapists doing telehealth visits instead of them having to come in to see a therapist. Can they do the exercises at home? Do they need to, change the exercises that they're doing? This helps with a lot of different patients that, maybe having difficulty coming into the physical therapy department. And so I challenge, any of the vendors that are out there. Technology is great these days. And, anything that they can be developing that helps the patient do things at the home that connects them to the health system, That's what's going to help patients not necessarily having to travel down to, a clinic or travel to the hospital. The possibilities are endless if, everyone begins to think of the unique ways that they can take care of patients these days.
Yeah, great point.
One other thing I'll add, if I don't break up here, Tamara's point around the devices and Michelle's point around the technology and the adoption, there's the wireless aspect of it too. And when you're doing all of this remote patient monitoring, sometimes some of our patients don't have Wi-Fi in their home or good Wi-Fi in their home. And all of this hinges on being able to get that communication through where you need to.
No, that's great. And just in the last 10 seconds or so we have a special guest that has just arrived. We'd love to bring him on board in just 1 second. But Pamela, do you want to answer that one last question that's up on the screen? With adoption of telemedicine, do you find that patients want access to communicating with the clinician 24/7? And you can talk about it.
Absolutely.
Absolutely. I think we could all say
yes.
Got it. All right.
I will say if you did adopt a children's health virtual visit, it's an application where the patients can do that. I think I talked a little bit about it in the presentation, but yeah, they want access 24/7.
Unfortunately, healthcare doesn't just take care of patients 8 to 5. It's a 24/7.
No, that's so true. And before we move to our next session, we've got a great guest panelist that has just arrived. We've got Stephen Klasko, who is the Jefferson Health CEO. He's just finished a book called The Manifesto for Health Assurance, not health insurance, but health assurance. Yeah. And we'd love for you, Stephen, to talk a little bit about your role obviously at Jefferson, and then talk about your book and what are you hoping to accomplish with it.
Happens to be right here. It's called Unhealthcare, a manifesto for health assurance. And by the way, great job on the panel. And what you guys are doing is really leading the revolution. But what I'm excited about this book is it's co-written with an individual named Hemant Taneja. Hemant is the managing principal of General Catalyst, Airbnb, Warby Parker, Stripe, and the largest healthcare IPO in history, Livongo. And what was interesting about Livongo is everybody told them, don't get into healthcare, it's impossible. It's now a $12 billion company. And I think what's interesting about what each of you guys is doing, while you're leading the revolution, what's cool about on healthcare, the first line of the first chapter says, so a Silicon Valley entrepreneur and a CEO of a 195-year-old academic medical center walk into a bar, start dating, and have babies. What would that look like? Because so much of it has been fragmented. It's been, I go to HIMSS. I'm sure a lot of you guys go to HIMSS. And it's, it's 870 25-year-olds saying, I'm going to transform healthcare. Here's my app. And I always look at, I'm a fellow of the World Economic Forum, and the CEO of Bank of America came up to me and he said, 30 years ago, the two sectors that had escaped the consumer revolution were banking and healthcare. Now you're alone. So think about this. We don't talk about telebanking. They don't have panels saying, oh, look, I've got this new app for telebanking. It's just that banking went from 90% of the bank to 90% at home. And by the way, if you're as old as I am, if we had a pandemic 25 years ago, we would have been worried about people lining up on Fridays to deposit their check in the bank. So we at Jefferson, we stopped talking about the technology. We talk about healthcare with no address. That healthcare starts not with a patient, because 95% of people are not patients. It starts with a person at home. And we start to think about from static data to continuous data. My car, I have a 2020 car, it gets better care than most people. Because while it's in the garage, it's sending data. And when I start it, it says, hey, Steve, while you were sleeping, my right passenger tire got a little flat. Could you fill it? Meanwhile, we have people dying of atrial fibrillation. So when we start creating wearables, connecting them, then one more thing. Then we have to think, and somebody brought this up, how we pay for that. Because there's a great quote from Upton Sinclair, it's hard to get somebody to pay for something when their salary depends upon them not doing it. So we have to start looking at how we get paid to make sure that all those people, Pamela, have broadband, and to make sure that our patient population is healthy. And that's a whole health policy thing that hopefully at a future summit we can talk about. But you guys did a fantastic job of really bringing up 3 or 4 different technologies that I think will change healthcare. And I'm an obstetrician. I'd like to bring up one more. There's one company I'm working with. I won't even mention the name, but so you think about people that have to get tested, and you have to go. I want you to come 3 times a week to Thomas Jefferson University Hospital to get a non-stress test. Oh, by the way, pay $35 parking. Take a 28-year-old. There's no chance post-COVID they're going to go, let me get this straight. You want me to come 3 times a week, go to a place where there's a lot of sick people, get on an elevator, stare up at the ceiling, so 2 hours later a nurse can tell me I'm okay. When I have this thing at home that I can watch Little Fires Everywhere with a glass of lemonade and have somebody come on tele, I don't think so. So I think we're at that I'm mad as hell and not going to take it anymore moment, especially in things like obstetrics. And you guys are leading the revolution. So thank you, and I'm really glad I had a chance to listen to what you had to say.
And we appreciate you joining us here, Stephen. We're looking forward to having you speak at the fall event later in a couple of months. And really the idea of this health assurance versus health insurance starts to make a ton of sense now that you've explained it a little bit. And we're now running over 2 hour, 4:30 Eastern session, basically called How Does the Healthcare System We Want Change? Is it ready to adapt? So we've got a great panel there. And thanks for Stephen, Pamela, Michelle, Tamara for pulling us through this. And we'll go meet you guys over there.
Great. Thank you.
Thank you.
Nice to meet you, Stephen.
Nice to meet you.
Michelle.
All right.
Thank you.
Thank you.